Okay, good morning, everyone. Welcome to Wednesday Morning Rounds. It's my pleasure this morning to introduce one of our interventional cardiology fellows, Dr. Ritesh Bajaj. He's been with us for the past year now. He began his interventional cardiology training in London, UK. And then in 2019, he undertook a 4-year break to pursue a PhD. And at that time, was focusing on multimodality intravascular imaging with IVUS and OCT. And so today he's going to be talking to us about invasive and non-invasive characterization of coronary atherosclerosis. So thank you so much. We look forward to your presentation today.
Thanks, everyone. Thank you so much for the invitation. Okay, I should begin by just prefacing the talk by saying that there's going to be a lot of acronyms here. So I apologize, IVUS, OCT, TICFA. There's a lot of acronyms in this space of cardiology. So it's hard to avoid. I'll take it as gently as I can, and I know it's early in the morning, but I'm hoping you'll just stay with me for this. So when I'm talking about plaque characterization, I expect everyone's thinking of some pretty pictures and things like this. This is a hot area of interventional cardiology at the moment, and imaging cardiology actually, and it's something that's a really hot area of research and something that's actually likely to impact patient management going forward. So I'm just going to do a brief overview on the invasive and non-invasive modalities we actually have for plaque characterization. But if we take a step back and ask the question, what's the actual value of characterizing coronary atherosclerosis? And when I say characterizing, I'm focusing mainly on plaque characteristics. So the imaging aspects of the plaque that tell us about its biology. So of course we can take images, angiograms, CT, and invasive imaging that can tell you how tight the narrowing is. We can absolutely do that. But we can also take pictures and try and glean from them exactly how much lipid content, calcium, etc., is in the wall of the plaque, and that may actually have a prognostic bearing on the management of the patient. Let's start with the fact that most coronary atheromas don't actually progress. The vast majority don't. In fact, a big study, and this is just one of the many studies that have been done, but probably one of the best quality ones, was published in 2010. And it showed that 75% of high-risk plaques with a vulnerable phenotype, these are the ones that are more risky, that may actually progress, were found at 12 months. 75% of them did just spontaneously heal on medical management. So actually, if you take the images of these plaques and put the patient on high-dose statins, control their diabetes, control their blood pressure, control their risk factors, 75% of them in this study healed at 12 months. So most plaques, even the high-risk ones, don't actually progress. There are plaques that do progress and have a higher risk of progressing, and those are termed vulnerable plaques, at least as far as this talk is concerned and what the literature would say. We call them high-risk plaques or vulnerable plaques. And they confer a risk of heart attack, death, and adverse outcomes. A large meta-analysis was published just at the end of last year, which looked at every study that's been done looking at high-risk plaque features and found indeed that if you pooled all of them together, that there is indeed a hazard ratio. And I'm going to get into some of these individual metrics here, but not all of them. But if you pool all of the different things that we look at and we call a high-risk plaque feature, a vulnerable plaque feature, then yes, that does confer a risk of adverse patient outcomes at the patient level and at the lesion level. So yes, high-risk plaques do absolutely confer a long-term negative outcome if they exist. Detecting these plaques may allow you to target changes to your treatment, so intensification of LDL control, things like that, and potentially allow investigation of new therapeutics. The next statin, the next PCSK9 inhibitor, the next thing that comes along that will actually allow us to target these plaques can only be done if we can actually image them accurately and follow them up accurately. Otherwise, we will need probably a much greater magnitude of patients and vessels and lesions to actually do these studies. So the studies become kind of prohibitively expensive and need to be followed up for much, much, much longer if you don't have an accurate way of classifying your plaques. So the other thing you can do is, of course, think about therapeutic target discovery if you have a way of identifying and looking at your plaques accurately. And the other thing for interventional cardiologists is accurately classifying your plaques, so characterizing your plaques allows treatment planning. And this is very intervention heavy, this bit of the talk, so I'll just skip through it very quickly. But PCIing lipid-rich plaques has an increased risk of periprocedural myocardial infarction and no reflow. PCIing heavily calcific lesions actually adds to the patient's risk during the procedure and may have an increased risk of stent failure, almost certainly does if it's not adequately modified. And we also like to know where our landing zones are. So in very diffuse vessels, it can be very hard to see where the healthy vessel is, and imaging can help try and elucidate that when it's difficult. The most important facet of all of these is probably the prognostication and identification of vulnerable plaques, because that's the thing that'll impact long-term on patient care and is probably the most important for primary and secondary prevention. It's early in the morning. I'm sure everyone's coffee's kicked in, so let's talk histology. So features of vulnerable plaques include thin fibrous caps and large necrotic cores. The other things that vulnerable plaques are famous for having is a very unfavorable biomechanical milieu. What that actually means is fancy terms like endothelial shear stress and plaque stress are abnormal. I'm not going to get into the details of this particular image because it's just going to give everyone a headache, but there are now biomechanical studies you can do. This has actually been done on a CT coronary angiogram of an LAD for one of my patients from the study I was a part of. And what I've done here is I've put in the center the fully opaque blue thing with the colored on top. That is actually the lumen of the patient's LAD. What you see in a semi-transparent fashion on top is the plaque burden. So that's the external elastic membrane. And I've also highlighted the macrophages we picked up from OCT. And then I've done some stress modeling on this vessel to see where the points of high stress are. And then what you can do with studies like this is actually at 2 time points, see how those factors relate to plaque progression. And this is entirely a research tool at present, but actually there are a couple of companies working to bring this into clinical frontline use and literally at the bedside with an angiogram be able to delineate things like this, because it may allow you to pick up points where the plaques may be more vulnerable. And that may be coming in the next 2 to 3 years to the coronary cath lab. Vascular inflammation is also a part of vulnerable plaques, and that's normally typified by the presence of macrophages. We used to have surrogates for these in the earlier studies and high sensitivity CRP, etc. And now you can actually visualize macrophages in the plaques, and it's a sign that those plaques are likely inflamed and therefore high risk. Non-invasive detection of coronary atherosclerosis is effectively done these days with CT coronary angiography. It allows you to see a bunch of different features, including the lumen stenosis, but it also tells you specific plaque features like low attenuation plaque, positive remodeling, the so-called napkin ring sign, which anyone who does read CT will be very familiar with, and spotty calcification. I have some examples of these right here. And this is a very nice example. This comes from one of the most recent reviews that's been published on the topic. And I wanted to put this up because this is a publication quality photo. This is one of the best examples they could find. This is the high resolution version of it. And you can see the problem with CT is the resolution. Is that you're trying to look at something which is 2 millimeters in diameter with something non-invasive. And this is as good as it gets. And the technology of CT scanners is improving rapidly, but this is where we are right now. And this is where non-invasive imaging is fundamentally limited just at this time point, but the resolution is improving basically year on year. And we are going to get to probably a state which is where these things aren't quite so blurry and the accuracy and precision of detection improves with CT. We're not quite there just yet, but we're working on this right now. The other thing you can do is look at PET, and this is not PET in terms of perfusion scanning. This is PET specifically using biomarkers that light up macrophages in the arterial wall. And this is really a research tool at present, done at a few centers. And PET is prohibitive as a tool for coronary artery characterization just because the radiation involved is a little bit greater. So I think it's very hard to make the case at present that it can be a prognostic tool. Those studies have yet to be done and the accuracy yet to be proven. The other thing is PET has too much of a, even greater than CT, too big of a pixel size. So actually, a voxel size, sorry. So actually your accuracy diminishes even further because it's just too much coronary artery movement right now to be able to see it very clearly. Invasive imaging is with IVUS and OCT. There is a new version of IVUS which includes this spectroscopy catheter called near-infrared spectroscopy that actually lights up in yellow around the artery, the arc of where necrotic core is present. And that's here is called LCBI. I did warn you there'd be a lot of acronyms in this talk. LCBI stands for Lipid Core Burden Index. But effectively, all it is a measure of how much yellow is on this screen. And the more yellow there is, the more necrotic core. You've got thin cap fibroatheroma, TICFA and OCT. You've got plaque burden, which can be either, but IVUS is probably better at it just because of penetration and minimal lumen area. And all of these are associated with vulnerability in plaques. This is what a typical IVUS looks like with a high-risk lesion. Plaque burden is increased and you've got attenuated plaque. So the IVUS signal fails to penetrate through. That normally means there's quite a lot of lipid there. The positive predictive value of this is pretty rubbish, the attenuation. It's something in the region of 22%. So it's not something that's actively used every day on the front line, but it can be a sign of vulnerable plaque. But with the positive predictive value that low, it's not particularly useful in clinical practice. NERS IVUS is a bit better. That's the same vessel, the same spot, but I've now turned on the chemogram. And here you can see that that is where the necrotic core is. And you can see the longitudinal view of where the necrotic core is in the vessel. And that can give you an idea of where to land your stent to avoid landing in lipid, which if you leave your stent landing in lipid, those stents tend to fail a bit earlier. And this is what NERS IVUS tends to look like. And this is something that's available on the front line right now in the cath lab. OCT gives you a similar kind of picture, much higher sharpness, of course, of the lumen. And you can see other things here. You can measure fibrous cap thickness, cholesterol crystals can sometimes be seen, and macrophages can sometimes be seen as well. That blue arc there is actually macrophages inside the wall. This is the same patient. This was studied by IVUS and then OCT. And here we've got a patient who had, if I go back, necrotic core and macrophages along the same arc. So that's all well and good. That's a quick run through of what we actually have as tools. Do we actually need any of this if we have stenosis? Would be a very reasonable question to ask. If a lesion is 90%, do you really need to know that it's full of lipid because it's tight and that's probably prognostic? Well, actually we do. The interesting thing is many serial studies with CT and intravascular imaging and angiography have now shown recurrently that around half of events seem to occur in lesions that at time point 1 had less than 50% stenosis. This has been shown repeatedly. And I've just picked a couple of studies just in the last 10 years that demonstrate this, but this is a recurrent theme in every study that keeps getting published. Chang published this story in article in 2018 in JACC showing that 65% of patients in a case control study looking at ACS versus stable angina, 65% of those patients had non-obstructive coronary disease at baseline and yet went on to have an event in that artery. In fact, when you looked at that artery specifically and that lesion, it was 75% with less than 50% stenosis. So these were patients, 75% of whom had no actual narrowing that was above 50%. It would be called non-obstructive. And those patients went on to then have a heart attack at their second time point, proven. The PROMISE and Scott Hart trials are considered landmark trials in CT coronary angiography, and they have shown a real incremental value and pushed CT up and up and up in the guidelines for first-line investigation for stable angina. They're landmark trials. If you look at both of these studies, in both trials, 1/2 of the observed MIs that occurred were in patients with non-obstructive disease at baseline. So again, half of the heart attacks are happening in patients with less than 50% stenosis. So stenosis isn't the perfect marker we would hope for it to be. The ROMICAT-2 study was another large CT study. In this case, if 21% did not have significant atherosclerosis, but every patient who then ended up having a heart attack and had less than 50% narrowing did have a high-risk feature, specifically that positive remodeling or the napkin ring sign or the other CT features we were discussing earlier. So if it's so great, and I've kind of tried to convince you that plaque characterization is additive in terms of its value over stenosis, why is it not in every guideline? Like, why am I here trying to make a case for it? And why is it not something we're using every day, all the time anyway? Because it's got a very high specificity, but a pretty unimpressive sensitivity. This is from that large meta-analysis that looked at every single vulnerable plaque study, and this is both invasive and non-invasive. I'm just going to highlight a couple of numbers here. Look at the sensitivity at patient level for thin cap fibroathyroma and large lipid core burden. Those are the best metrics we have. Those are the reference standard in vivo right now. 53% sensitivity, 67% sensitivity. Look at how wide those numbers are, and the positive predictive value is absolutely appalling. If you look at it at lesion level, it's even worse. 9 positive predictive value, 3. So these are not ready for prime time. They have a very high negative predictive value. So if these features do not exist, it's very unlikely to be vulnerable plaque. But if they exist, it's a little non-specific as to whether that actually is a vulnerable plaque. And this is the problem with where the field is right now, is that we are just limited. In red, you'll see the CT markers, which actually are not terrible, but really, again, not ready for prime time. You'll notice high plaque burden consistently comes up with a high sensitivity, but a low positive predictive value. That's been shown again and again and again, and it's something we're just not very good at looking at. I suspect what the lesson of this slide is that you're trying to pick up biochemical signatures in the plaque based on imaging, and our imaging just isn't good enough to see that deeply into what's happening chemically within that plaque and whether it's actually at high risk or not. So I think this is an area that needs to just improve as technology and new imaging modalities come along. So our limits of plaque characterization in vivo that we've seen before can probably be explained by the fact that in non-invasive imaging, the resolution just isn't there yet. Major studies looking at imaging, CTCA specifically, have correlated plaque features with MACE events long term. And that's useful, but then you're trying to correlate that back to whether that particular lesion was involved, and that's a much harder thing to do. So yes, having high-risk features means that patient has an event. That could be stroke, that could be something else. You're picking up the vulnerable patient as opposed to the vulnerable plaque. That might be the issue there. And comparative studies that have been done with CT tend to be done against intravascular imaging, because as you can imagine, doing a histology study with CT is quite tricky. There are a couple. There's a company named Elucid that's trying to validate an automated plaque characterization thing with CT, and they've done it with animal studies and histology. And they've got their algorithm and tool out now for sale, actually. And it's already being sold to CT departments around the world to help pick up necrotic. And they have some interesting work on histology, but it's still a watch this space moment right now. Invasive studies have all been validated against histology. Typically, if you look up those histology validation studies, you are validating them against 300-400 slices of histology and then saying, right, this applies to every human being and every plaque on the planet. And that's the problem with them, is they're small studies. And even though 300-400 slices of histology can take years to validate, it's still just not a very large cohort to train with. And this is just a thing that needs to just improve with time. Larger studies are just needed, and large studies will probably improve your accuracy. The studies that have looked at CT versus intravascular imaging, I'm just going to pick up a couple of recent ones. There was one in 2014, which found that low attenuation plaque, which is one of the more reproducible markers of plaque vulnerability on CT, had a 59% sensitivity in detecting tick fuzz, which had been seen by OCT, which is currently the gold standard for picking up tick fuzz. CT versus NERS-IVUS, this study was done in 2023 and published in a very prestigious journal, found that low attenuation plaque had a 78% sensitivity. However, if I then tell you that this is judging it against an OCT standard, which is the reference standard here, OCT's detection for TICFA is probably around 70% accurate against histology. So you've got 59% accuracy against a modality that's 70% accurate. And you've got here 78% sensitivity against a modality that's around 75% sensitive. So you are taking something imperfect as your reference standard and then applying something that will try and capture that. And that's the problem with trying to do these validation studies with CT, is that if you're going against a reference standard, which in itself is slightly imperfect, histology would probably be the gold standard, but these are harder to do, these studies. The true validation would probably have to be histological at some stage. Currently, it's all intravascular imaging versus histology, and then CT and PET versus intravascular imaging. And if you just look at CT versus intravascular imaging, you get an image like this. This is that vessel that I was looking at for. Actually, this is that patient's circumflex. And here is the CT longitudinally for that patient. And here is the NERS-IVUS for that patient. And you can see, I just used the calcium and lipid. Yellow is a lipid, white is calcium, and everything else is neither. So just fibrotic plaque. And here, this is based on CT. Yellow is based on Hounsfield units, and simply looking at a marker of low attenuation. And you can see actually the difference between the two just within the same vessel. What you can do with studies like this that compare intravascular imaging with CT is then you can take a large enough number of vessels, and we published this recently. We had 75 vessels with intravascular imaging and with CT, and use the intravascular imaging to train a deep learning model to better detect your plaques, and then you can actually improve. This is after deep learning. You can slightly get closer to what your reference standard is, albeit that is also slightly, it may not be a perfect metric, but it's as good as it gets in vivo, and you can improve your prediction just by trying to train it off of intravascular imaging. Coronary inflammation imaging is a bit of a hot topic. Every couple of years, there seems to be a large major study published in this area. It's not hit prime time just yet, except for fat attenuation index, which is now available in certain CT reporting labs and may become available in more as the studies kind of come through. The theory is that coronary plaque inflammation alters the composition of your epicardial fat near the artery, and that allows you to pick up attenuation in the fat that you can pick up by CT. The first and big study that came out that proved this point was in 2018 in the Lancet, and they called it the Fat Attenuation Index, FAI. But that's basically all that is a fancy way of saying that there is attenuation near the artery that doesn't exist in other arteries, and that is a marker of inflammation in the plaque of that artery. And they found that this Fat Attenuation Index actually improved mortality prediction over and above every other CT criteria that they had. And there are now lots of blood studies happening looking specifically at how much fat attenuation index adds to your prediction of vulnerability in the plaque there, where you look at this. The PET imaging modalities are based on dotatate, and there was one large study that in 2017 that has not been replicated yet that showed that dotatate, which is a marker that binds macrophages, specifically the SSTR2 receptor in macrophages. And this study showed that this marker binds to inflamed plaques and in patients who'd had a heart attack or a stroke. They also did it in carotids and tried to demonstrate that you can actually get these plaques to light up on a PET scan. This study has not been replicated since then. In 2019, another study was done, and that was actually negative. And then there's a third study that's about to come out, which will hopefully try and answer this question about whether this works or not. I'm pretty confident that dotatate actually does bind macrophages. The problem is that PET is looking at something that's 2 millimeters in diameter, and then your actual voxel size is 3 millimeters. So just the amount of resolution just isn't quite there to image this properly just yet. Sodium fluoride caused a bit of a stir when early studies published in the Lancet around 2016, 2017 showed that sodium fluoride picking up early calcification actually predicts and picks up high risk and vulnerable plaques. And there was a lot of interest in this study, which unfortunately came up, unfortunately came up negative. This was a study looking specifically at whether sodium fluoride activity was associated with MACE events, and it just wasn't. So this was a negative study looking at this. This came out in 2023. This is another example of PET lighting up around a plaque. That artery I was showing you before, that LAD, this is that same patient, and this is the PET around that artery. And we're trying to correlate macrophages picked up by OCT with the PET signal around that artery. This needs to come out in the next year, probably. We'll publish this paper at some point once all the vessels have been analyzed. So vulnerable plaques, you can kind of try and detect them in vivo, but what do you do when you find them? Because this is still really a gray area of what you actually do. There is no evidence that fixing them or intervening on them makes any difference at all. Those studies have just not been published yet. And they don't exist, in fact. Intensification of LDL targets is one thing that everyone says. I think cardiologists are slightly hamstrung here. By the time a patient comes to see a cardiologist, we're already putting them on the highest dose statin and already getting their LDLs down to target. So what further intensification can there be? PCSK9, potentially, but I would have thought we would do that for any patient anyway whose LDL was off target and they're seeing us in a tertiary center. So you can consider that. More recently, there's been some discussion about whether PCI actually helps these patients. I must rush to add, those studies don't exist. This is not in the guidelines. PCI to passivate, to try and stabilize plaque, is a thing that's entirely theoretical. There has been one study that's looked at that. The PREVENT study came out just a couple of months ago in the Lancet. I urge everyone to take a look at it who's interested in this area because it's fascinating. This is the first and only study that shows that PCI plaques that are vulnerable phenotype with intravascular imaging improves outcomes. But the reduction is just a 3% absolute risk reduction at 2 years. And if you look at what's happening in the patients who are just treated with statins and aspirin, the event rate is tiny. So 3% absolute reduction, yes, fine, it's reasonable, and it was significant, but you had to put in something like 84 stents to prevent one episode of stable angina. So this is not some huge difference in MACE outcomes with cardiovascular death, stroke, MI that we're seeing. These are marginal benefits. Putting in 84 stents to achieve one patient, I'd leave that to your interpretation of whether you think that's worth the lifelong risk of in-stent restenosis, etc. So in conclusion, plaque characterization is useful, but it's an imperfect tool. You can do it both invasively and non-invasively. The invasive is probably the current reference standard just because the resolution is best invasively, but is it in itself imperfect? And to be honest, invasive plaque characterization, while we as interventional cardiologists like it because we can use it at the front line, I think and at population level, it's going to be one of these things that's only ever limited to certain use cases and not broad, because you can only ever use it to see the bit of the coronary tree that you're actually imaging. You can't take it down and see every single side branch. CT can see the entire coronary tree. We just can't do that in the cath lab table for every single diagonal and obtuse marginal in every branch the patient has. So really, it's only useful in a secondary prevention setting. CT, when it gets good enough to pick up high-risk plaques at scale, will be something that can be applied to primary prevention. That'll be a more interesting treatment and a more interesting kind of avenue moving forward. The imaging features are trying to extrapolate a biochemical compositional signature within the plaque based on what you're seeing, by how much the light or the ultrasound is being attenuated by that plaque. And I think fundamentally, that's probably just limited in terms of what you're trying to achieve with what's possible with imaging. Whether you believe that fibrotic plaque and lipid plaque reliably attenuates light ultrasound CT signals the same way every time, every patient, it's very hard to be just logically say that that's reasonable, because these things are happening at a micron level, and you're trying to use something that probably doesn't image it at that level. Coronary atherosclerosis is dynamic. Plaques evolve. I've already shown you some evidence that plaques, which are less than 50%, about half of them end up causing events in these studies. So that single time point imaging may not be the perfect way of picking up vulnerable plaques. I suspect where the field is heading is serial imaging will become the way forward, where you'll end up doing CT scan 1 and CT scan 2 at 2 different time points. What that second time point's length will be and whether you would even consider it, I don't know, but I think that's where probably the field will go in the next 10 years. And you'll probably risk stratify patients by doing CT scan 1, CT scan 2, comparing the two and seeing how much progression there is. And those will be the truly vulnerable patients in plaques. And that'll be of interest going forward. And you may only do this in patients who have very high familial hyperlipidemia, type 1 diabetics, etc., patients who are truly very high risk. But I think that's where we're headed. Intervention and therapy for vulnerable plaques is a hot topic. It's an aggressively studied area. There's a lot of money behind it. There's a lot of large-scale studies going on. And therefore, plaque characterization imaging is going to hang around, because all of those studies, every single one of them is entirely dependent on the imaging modality they use. Some of them are using CT, some of them are using intravascular imaging. And that's why, even though this is an imperfect tool, it's just going to keep being on frontline use, because it's just absolutely essential to getting these studies done. If this tool wasn't there, all you'd end up with is you need probably 10 times, 100 times the number of patients, a much longer follow-up, and then just wait to see events, which is probably a better study, but also much more expensive and much more unfeasible to do at scale. And I'll finish there and take questions.
Thank you so much. If you have any questions, please put them in the chat box if you're online. Otherwise, I think Dr. Chi has a question.
Hi, Rajesh. Thanks. That was very interesting. For the plaque characterization, is the software currently, does it allow you to quantify it, or is it more sort of qualitative? Yes, no.
So, yes, absolutely. Every single software allows you to quantify it. Yeah, are you talking non-invasive or invasive? They both do, but
both non-invasive and
okay.
invasive.
So the non-invasive one, every single Siemens, GE, Toshiba, all the big makers of CT will allow you to quantify it automatically de novo in their software. They base it on the brightness of the signal. So they'll just call calcium when the signal is above a certain HU and lipid when it's below a certain HU. Elucid is a company that's developed a thing that's not actually based entirely on the strength of the HU itself. They've actually put in some machine learning and based on histology. And that's quite interesting, because it seems that might be more accurate than what's just based on X-ray. So that exists, the software exists. You'll need to pay a license fee to use every one of these softwares. And every software has its own pros and cons. I didn't get into software in this talk because it'd just be too big. OCT software exists as well. There's 2 or 3 different types. NERS-IVUS software exists as well. And IVUS software existed. It was called VH-IVUS in the early to mid 2000s, and then it's now no longer sold by the company because lots of studies have shown that it's just unreliable, and the kind of quantification is not
So,
accurate.
so for intracoronary imaging, invasive imaging,
Yeah.
how I don't understand how you actually quantify, let's say, the macrophage burden. Like
Right.
how is
Yeah.
it done?
Well, so there's different ways. You can actually quantify it based on, so you need a lumen measurement and an external elastic membrane measurement. And once you have those two, then it's just about counting the pixels and saying what's the area in between the two. And for instance, in this study, what we did was we actually had the external elastic membrane and lumen for IVUS and CT. And then you just say, right, how much is lipid, how much is calcium, and how much is neither. And then you just compare the two values. So you've got areas for direct comparison. And you can do volumetric as well then.
So the studies that show that there is incremental value for plaque characterization over just sort of whether they've got stenosis or not, for predicting major adverse events, is that on top of plaque burden?
Yes.
Right.
Yes, there is. It's on top of plaque burden, above a plaque burden. Yes.
So quantitative plaque
Quantitatively.
burden.
Yeah. In fact, it's so I showed the results for the binary presence of necrotic versus not, but in those studies they also have volume of necrotic core and area of necrotic core per slice. They have that as well. So, and those are significantly associated. The positive predictive value still isn't great, but the hazard ratio comes up as it hits significance. So it's not a perfect marker, but yes, it does seem to add something on top of stenosis.
And this is presumably multi-vessel analyses, not just single vessel.
Correct. The best OCT study that's come out so far is the CLIMA study, and in that one it was a minimal lumen area, and then also the TICFA and angle of macrophages and other things. So they had other characteristics. That was based on OCT. That was only LADs.
So
but
yes, so that's lumen area though. So as you know, in CAV, for example, we're interested in intermole thickness.
Right.
So when you say plaque burden, that's quantitatively assessed invasively, and that characterization has incremental value above that. You're referring to the lumen area and not the plaque burden.
Only because of CLIMA in particular wanted lumen area, but the IVUS studies have all done plaque burden. Plaque burden is a better measure than lumen area. Anyway, yeah.
There's a couple of questions online. Dr. Shamoon has two questions. So his first question is there any thought on HSCRP or future novel markers specific to vulnerable inflamed plaque to assess risk? And his second question is there a role of AI in interpreting this data?
I actually think the only way to I'm going to take them in reverse order, if that's okay, Dr. Shimon. I actually think the only way to interpret images like this for CT and ultimately intravascular imaging will be via AI, because I just think human beings, even core labs, are not very good at looking at these images. And I had to delete some slides this morning because I thought it'll go too long. But one of the slides I had was a core lab analysis that looked at effectively the top 5 core labs in the world for intravascular imaging, and their kappa for picking up vulnerable plaque was 0.22. These are experts who are on all of the boards we would recognize, names we would recognize from the top core labs in the world, and they cannot agree with each other looking at the same image that it's a vulnerable plaque or not. And those are experts who just do this for a live, like they just look at vulnerable plaque on OCT. That's all they do. And their kappa is 0.22. That was in JACC imaging in 2023. And that tells you that experts are not very good at. That's why I think machine learning will have to come along just to reduce the inter-operator variability of how we're looking at these images. So there's something reproducible, because currently it's being done by humans and it's really not reproducible. In terms of high sensitivity CRP, I think it's already been recognized as a marker. I don't think we use it, but yeah, it is a marker. Like if you have high, the problem is it's very non-specific. I suspect if your HSCRP is low, probably you're a less inflamed person in general, and you probably have fewer vulnerable plaques. But this is probably more at a patient level. So if it's high, what does that mean? It could mean that you probably have rheumatoid arthritis or something else going on, or you are probably type 1 diabetic and have high LDLs, etc. It could be very non-specific.
One more question from the chat, and then Dr. Beanlands has a question. Dr. Chan made the comment, the main limitation of non-invasive coronary imaging is low resolution. What are the new developments addressing this? One of the responses in the chat from Dr. Ahmed was that photon counting cardiac CT provides ultra high spatial resolution.
Yeah.
And this is being used in some US centers.
Yeah.
Do you have any comment regarding that?
So it's very exciting. The image quality is remarkably good. It just hasn't, the trials looking at MACE events haven't been published on that, so I didn't get into it. But photon counting absolutely will improve the resolution. Also, the new PET scanners are coming out with much less radiation, so PET inflammation imaging might improve with better resolution and lower radiation. But I tried to keep the studies just for brevity's sake that have MACE events and kind of hard outcome data at present. So this is a really hot area of research. So I'm sure it's going to be wider spread once it gets out.
Excellent, fantastic presentation. Thanks very much. On the AI point, I would be cautious, especially when the agreement is really low, because it means that we don't know what truth is.
Yeah.
And if we don't know what the truth is, the AI won't know what the truth is either.
Absolutely.
Right? So I still think that there's a way to go. One other problem is that there's good and bad macrophages. And so when we're defining macrophage, and this may be part of why techniques are not as predictive as we would like them to be, because some of the macrophages are doing good things to the plaque and others are doing bad things.
Yeah.
And I kind of wondered, what is the validation? You mentioned histology for each of the methods for defining the macrophages in the plaque.
So the histology studies on macrophages, they're looking at type 1 macrophages within the fibrous cap. Technically, that dotatate tracer that I mentioned technically should only be picked up by type 1 macrophages, which are technically more inflammatory. So hopefully, and I say hopefully, and I'm caveating it a lot because really this is as good as it gets, and it's not perfect. And the people who do these studies will tell you it's not perfect. It's just there is no great biomarker. The other thing is you're trying to do a PET ligand to a macrophage and then putting it in a PET scanner. I mean, what are the chances you'll pick it up at something that's less than 45 micron? You know, it's very hard to be sure you will even pick it up because there may just not be enough tracer.
So
and if you pick it up, what does it mean? Yeah.
Right, but that technique, if I can expand on it a bit, it's basically, you're right, you're not going to get the resolution, but you're going to get a measure of inflammation that's quantifiable.
Yeah.
And the other piece is, yes, you're focusing on the coronaries, but there's other vasculature that can be inflamed. And Kevin is looking at this in the carotid and aorta, in people with recent infarcts and so on. And so it doesn't have to be the plaque burden and the inflammatory plaque and the patient at risk, the vulnerable patient, may be definable not just in the coronaries, right? So to sort of be thinking outside the coronary tree in terms of predicting events is where the CRP may be of value, but other techniques looking at other measures, and then you don't need their resolution unless you're specifically directing your therapy to the plaque.
Yeah, I think that's a very interesting and exciting point, actually, because the aorta and carotids probably is much better. There's less movement. And I suspect you're right. You'll pick up vulnerable patients, which may well correlate to vulnerable events. And I think that is probably where it'll end up going, because I just think the coronary movement is too much. Just doing a little bit of this in my study.
Certainly for PET, the movement, and is probably why the second study wasn't, their motion correction may not have been as good as the Edinburgh study earlier for the sodium fluoride. But it's the big hurdle is how do you manage the motion of the coronaries to get the imaging?
It's interesting.
Or PET imaging anyways.
Absolutely. It's interesting. The only positive study, about half of the lesions they had were carotid lesions after a stroke.
Yes.
So if you do, I haven't looked at it in great depth, but I wonder what happens when you take those patients out and then you're just left with 22 patients with a heart attack, and whether that's enough power. It probably isn't enough power to pick up the point.
You also made the good point about the fluctuation, and we do see that with PET and the carotids and aorta, that the amount of over time, there'll be plaques that become less hot and there'll be others that become hotter. And so there is this fluctuation over time, even within a given patient. which makes it even harder.
Yeah.
Also, I would be, when you show the sensitivities, I would be cautious of not being too strict on the prediction of MACE.
Yeah.
It's not the sensitivity that you're looking for diagnosis, which
Yeah.
you want 85, 90%. You're looking at predicting events, which is a much harder standard to be comparing sensitivity and specificity.
Absolutely. Absolutely. I think it only works for MACE probably because you're doing vulnerable patient as opposed to lesion, which
Right.
you're absolutely, you make an excellent point. Absolutely.
Just a comment on the AI. I do think that AI is the answer. I just think that we got to take a step back. I think the way it's going to work is that you're going to collect the data, and then you're going to have longitudinal studies on MACE, and then you're just going to throw it into an AI, and then the AI is going to tell you what's important. Maybe we're looking at the wrong target. Maybe this thin fibrous cap is a surrogate for something else completely, right? And so, there's lots of neat studies about how AI is picking on things
that you wouldn't think were
that
important.
you don't think about
Yeah.
exactly. So
Yeah.
I think AI is the answer. We just don't know. I think you just have to collect longitudinal data, lots of images, and let the AI figure it out.
Yeah. I think that's a very good point. Yeah. Right.
Not the actual.
Right. Yeah. Your hard clinical event must be your reference. Yeah. Yeah. Absolutely.
I think Dr. Chow has a comment. He's signed in online. Ben, can you unmute your microphone?
Yeah, thanks. You can hear me, right?
Yes, Dr. Chow.
Okay, perfect. So fantastic talk. I think many of us who read CT acknowledge all the limitations that you've outlined. So I think, critical information to speak to plaque volume, plaque quantification. There is automated software that does it. That's kind of vendor specific, but I would say very inaccurate. So I think to put it in context, at this point in the game, I would not expect us to report or expect the CT readers to report volumes per se, whether it be low attenuation plaque, et cetera. If you look actually the studies that have been done, they actually have human readers that have basically segment out the artery in short axis millimeter by millimeter, which is to get it done accurately. And even then, the predictive value, as kind of was highlighted in your talk, not super great. The other kind of learning point and teaching point exists on this slide, right? So this is, I think, a take-home message. So if you look at your slide, the middle image is basically what we as human readers see in terms of quantification of plaque. So the overlap of the orange and the yellow, a lot of the, let's say, readers at the Heart Institute would say, yeah, those portions of the arteries are normal. There's no plaque. And then with your AI training against IVUS, the separation between orange and yellow, right? And so when we tell on our CT report, when we say that this 75-year-old man has no atherosclerosis, I'm going to tell you that we're going to be wrong. Right now, having said that, the burden of atherosclerosis predicts outcome, but we're not 100% accurate. So I would take our interpretations with a grain of salt. Some of us are a little bit more sensitive than others and will call plaque when others won't. So there is going to be variability within readers.
Yeah.
But I think the bottom image is truth. And unfortunately, the middle image is currently where we are visually, which I think, I would suggest that all of the individuals that are looking after these patients kind of take into account.
So it's such an important point, Dr. And just to extrapolate a little bit on this, just to give you more information, that middle drawing right here that you're seeing where my mouse is, this was drawn by our CT core lab, who are basically our London experts for CT drawing. And they are, if you just look here between the lumen and the celestial membrane, how much of the plaque they're missing compared to when it's retrained, and this is by AI. And the reason is, it's just with CT, even experts are missing the fact, look at all the plaque that's being missed here, just in this slice. That's the plaque burden, the plaque volume that's being missed. And that's the single most important metric for kind of lifetime risk of MACE of all of the ones we've talked about. And this is with an expert drawing it. And that's part of it. So it's not just the characterization, it's how much plaque you just can't see. And that's because I do think CT is the future, but I just think where the modality is now is right now, even an expert, even two experts would disagree between each other about how much true plaque, fibrotic plaque this patient would have, for instance.
That was excellent. Thank you so much. Great discussion this morning. Have a good week, everyone. We'll see you next Wednesday.